Chair, I yield back.
Thank you, Mr. Meyer. And we expect a couple of our senators to come back. So, but I do want to jump onto a couple of things. Dr. Meyer. Okay, so you have an expertise in Medicare Part C. As you know, part of our team for a year or two have been trying to, I've almost memorized the MedPAC report. If you ever look at mine, it's a little dog-eared, if that's the proper term. If I came to you and said, even with, what is it, the B28 trying to, deal with our risk adjustment modeling, how about going to a classic, true capitated model? That if you're an organization, provide the service, but make money because you helped your population be healthier and therefore a lower utilizer of services. So, as you know, we've written a piece of legislation to functionally end the star rating, move to elimination of risk scoring. So you would do your risk score model in your initial bid, and then once you have your population, you get one more shot at its actuarial recapture model. So if you end up with high levels of, a meteor hits part of your population, you actually have sort of a reinsurance model within it. My state's Medicaid system actually does something like that. Why is that not a more universal solution than trying to play whack-a-mole with risk scoring?
Yeah, I think that's, thank you for the question. That's a really great, set of ideas that are included in that legislation. And I agree, I think that to fix the issues in Medicare Advantage, it probably does require these larger scale fixes that don't just get at sort of one of the individual incentives, but sort of address the larger structural challenges with the program that right now plans are not actively incentivized to actually invest in improving beneficiary outcomes. They're incentivized to maximize payment in the short term with the expectation that somebody's just going to leave the plan in a couple years and those benefits are going to
with that point, we sat down with a number of actuaries, and part of the model said is, you have to move to longer enrollment periods, so that investment in helping someone be healthier, obviously you have to have, someone's unhappy, the ability to leave at a certain point. And the actuaries sat down with us and said, look, you got to have like 3 years sign up. So if it's obesity or hypertension or something where you're trying to manage a chronic condition, that for the first 2 years it may be expensive, but third year you gain a benefit because you help that enrollee be healthier. Your opinion?
Yeah, I mean, I think could be a lot of potential in a plan like that, as long as there was sort of that escape hatch if somebody was sort of in a situation that the plan wasn't working for them. But I think that there are opportunities that we can think more creatively than sort of the current model that we're currently using, and that's definitely one way to potentially reform the system.
All right. Universal question for all four of you. I come to you tomorrow and say, I need as fast and universal solution to bad acts in everything from Indian Health Services to Medicaid to Medicare to health, TRICARE. Is there a data model that you've read about, thought about, had presented to you that, because I'm starting to believe our Congress's ability to think through dozens of little improvements instead of saying maybe we can find a universal one and maybe it lays within technology of identification, technology of plan models, technology. Where would you take me?
I mean, I would tell you that the way to reform healthcare programs is to focus at the underlying incentives, and the incentives that we have from federal health programs right now are for more spending. It's the way that works in Medicare, Medicaid, the ACA. I think technology has a role, and I think improved data analytics from AI and being able to stop inappropriate, suspicious payments before they go out the door certainly has a role. But there are so many distortions that have been caused by government payment policy. I mean, the Medicare program is a set of price controls that the entire health sector has organized around. I mean, Senator Hassan, you have legislation that would address one of the most severe distortions, that we pay more for hospital-based services than we do for the same service in a physician office. That encourages a lot of this consolidation. I think we have to look at where government payment policies have incentivized so much of this waste.
Dr. Meyer.
Yeah, I think it's a great question, and I actually agree quite a bit with Dr. Blase that I think there are opportunities so you can have a better plan finder tool using technology that can take some of the role of the brokers. You can have a more AI-informed risk adjustment model that can address some of these coding issues. But I think that technology largely overlays on top of the larger incentives that are at work. And that technology is both available to the government, but it's also available to sort of the plans and the providers and the other actors in this space that will use their own sort of technological solutions to be on the other side of the table from this. And so I think that there's a lot of potential there, but I think it needs to probably be partnered with these larger reforms to the system that you and others have proposed as well.
And is the reform moving to a capitated model? What's the universal reform?
Yeah, I mean, I think we should move it to a capitated model across the board, that the federal government can't provide open-ended reimbursements for everything.
All right, Dr. Pope.
I think the most important role of better data here is really going to be in the Medicaid world. I think we can't underestimate how little we know about the Medicaid program, just because we have 50 states with entirely different Medicaid programs. The benefits vary enormously. The types of providers that are engaged in the Medicaid program vary enormously. Payment rates are sometimes routed through MCOs, sometimes not. We have enormous webs of cross-subsidies that are going on throughout the healthcare system. We, quite frankly, from a policy point of view, don't know what we're paying for. And until we try and cut a payment on the left, and then it shows up that it creates a problem on the right. So I think there is a sense in which better data can indirectly give us a sense of what the Medicaid system's even trying to do at this point. And that would be a real step forward relative to where we have been.
So I think what strikes me the most about this is how diffuse the responsibility is for oversight and how limited visibility you have into some of this information. So I think a priority would obviously be letting the systems talk to each other, data sharing in and of itself, not just necessarily the silver. I call technology the bronze bullet because it depends on so much. It's not the silver bullet. And so for me, a lot of this gets to data sharing, which is something GAO has focused a lot about. But you did ask about bad actors and not necessarily about improper payments or honest errors. And so one is letting the systems talk to each other. And I will also say, just for both the sake of the spread of bad to honest but improper, GAO has many recommendations on its website where it's detailed solutions that I think are excellent that deal with this. And so they have actual structural responses that I think we could learn from. But another one I want to point out, because you did ask about bad, and this is not data, it's actually about humans, and it's protecting the whistleblowers. So we know that one of the biggest reasons we have such significant recoveries, particularly through the False Claims Act, is through whistleblowers or the key TAM relators. That is the biggest driver of recoveries when we're talking about actual False Claims Act violations and misrepresentation. And currently, its constitutionality is being challenged. Right now, it's before the 11th Circuit. And the elimination of that really important channel, if its constitutionality, if that decision gets upheld, is going to be devastating to this country's efforts to claw back that money. But I agree, it doesn't get to the front end, which is how are we going to deal with this from a data perspective, which is, again, I think better talking, let the systems talk to each other.
And look, I have an absolute fixation. I'm tired of our government paying and chasing. How does the money, many years ago I was Maricopa County Treasurer, and this is simple compared to what we're up against, but we just went to a positive pay model. We loaded the data file and then that's the checks that went out. And if they didn't match, it didn't get paid. And in a modern world, there's got to be a way we can start to see, you saw some of the hospice fraud we've been chasing down in my Ways and Means oversight. And when I have multiple hospices all in the same P.O. box, maybe we should have seen that. Or the same patient being rolled repeatedly into different hospices. maybe the data system should have seen that. So some of this is obvious data management. And Senator Klobuchar, I've stalled just long enough. It's your turn. Senator
Thank you. We
Hassan
have
has
two
a couple.
votes,
So
Do you want to, it's fine.
no, it's all yours. And
Okay.
then,
All right.
because we've had a brilliant conversation, and I still haven't found my data system yet.